This PowerPoint covers adrenal cortex hormones, mineralocorticoids, glucocorticoids, and androgens. It will touch a little bit on the adrenal medulla hormones, but not too much. The adrenal gland, also known as the suprarenal gland. It's located on the superior aspect of the kidneys. It's bilateral. There's one on each top of each kidney, and it kind of looks like a party hat to me. It has two distinct parts, a medulla, which is the center portion, and a cortex that surrounds the medulla. Adrenal medulla origins. The adrenal medulla is derived from embryonic neural crest cells during neuralization of the embryonic phase. It is functionally related to the sympathetic nervous system. The adrenal medulla's function. It's innervated by preganglionic sympathetic nervous system axons that release acetylcholine. It is considered a displaced sympathetic chain ganglion because it acts like a postganglionic axon, as when it's stimulated, it releases hormones or neurotransmitters, epinephrine and norepinephrine, into the bloodstream. The adrenal medulla hormones, it produces catecholamine hormones and secretes them in response to the sympathetic nervous system stimuli. Catecholamine hormones are classified as protein or polypeptides, so it has all the properties of a protein polypeptide. That means it is water soluble, so it can travel without being bound, and that its receptors will be located on the target cell membrane. And it typically will, the target cell will be a metabotropic in most cases, where it's linked to a G protein. The order of production is that the norepinephrine and epinephrine all derive originally from tyrosine, which is also the same amino acid for thyroid hormone. So from tyrosine it goes to L-DOPA, and from L-DOPA it goes to dopamine, and then norepinephrine and epinephrine. We went into detail how these were synthesized in neuromuscle, so I'm just going to leave it at that. Adrenal cortex hormones. Now we're focusing just on the cortex hormones, and we're done talking about the medulla. There are two major types or categories of the adrenal cortex hormones. They're mineralocorticoids and glucocorticoids. All adrenal cortex hormones are steroids, so that means they're all initially synthesized from cholesterol. Mineralocorticoids are named that because they affect the concentration of some minerals in the body, particularly sodium and potassium. Glucocorticoids are named that because they affect the concentration of glucose in the body. There's a minor hormone, or a couple of them, of adrenal cortex hormones, and one of them is androgenic hormones, or just androgens, and they have the same effect as the male hormone testosterone. These are produced in both male and female adrenal cortex, so that it doesn't matter the gender. The adrenal cortex makes androgenic hormones, and they have the same type of effect as testosterone, is that they significantly increase protein synthesis. And then estrogen. The adrenal cortex hormones are also estrogen, the androgenic type. And they, again, are produced in both male and female adrenal cortex regions. Now, I remind you again that they're steroid hormones. All adrenal cortex hormones are steroids, so they're lipid soluble. Most of them have to travel bound, and that the receptors are located within the cytoplasm. Anatomy of adrenal cortex. The cortex is composed of three distinct layers. The most superficial layer, or the outermost layer, is the zona glomerulosa. The middle layer is the zona fasciculata, and it makes up about 50% of the cortex. So if you can remember, there's a lot of the zona fasciculata. Then the zona reticularis is the deepest layer of the cortex. The zona glomerulosa produces primarily aldosterone, which is a mineralocorticoid. If you remember, aldosterone affects the kidneys, And the kidneys have these little structures in there called glomeruli or glomerulo. So that hopefully will help you remember why it's called the zona glomerulosa, because it affects the kidneys. Production of aldosterone is controlled by adrenal corticotropic hormone produced by the anterior pituitary gland. However, secretion is controlled by the release or increase of angiotensin II, a type of plasma protein, and plasma potassium levels, particularly if it's high potassium plasma levels in the blood. Those will control the release of aldosterone, where the production is controlled by ACTH. The zona fasciculata primarily produces cortisol, which is a glucocorticoid. Its production and secretion is controlled by ACTH, adrenal corticotropic hormone. So cortisol has both production and secretion controlled by ACTH. The zona reticularis produces the small amount of androgens that I talked about, androgens and estrogens. Some of the androgens it makes is dihydroepiandrosterone and androstenedione. The production and secretion of androgens and estrogens of the zona reticularis is controlled by adrenal corticotropic hormone, or ACTH. Now, cholesterol is the main precursor of all steroid hormones. They're all synthesized from the cholesterol. The adrenal cortex cells can synthesize about 20% of the cholesterol they use or that they need to make the steroid hormones. So the rest of the cholesterol, 80% of the cholesterol that the adrenal cortex needs to produce these hormones, it has to get from circulating blood. Steroid hormones and low-density lipoproteins. Most, about 80%, of cholesterol used to produce adrenal cortex steroid hormones comes from circulating low-density lipoproteins. You can see in that drawing there where it shows a receptor on the cell membrane of an adrenal cortex cell, and that it shows a little low-density lipoprotein binding with it, and that it is taken into the cell via endocytosis, and then it goes through all this process of being liberated so that the fatty acids can be used to make the hormones that the cortex needs to make. Adrenal corticotropic hormone and steroid hormone production. ACTH increases LDL receptors on the adrenal cortex cell membranes. So that's an important feature because you can't make the hormones without cholesterol, and 80% of the cholesterol comes from circulation and blood, and then the ACTH gives the adrenal cortex cell the ability to take up a whole lot of low-density lipoproteins. The mitochondria, via enzymatic reactions, will convert this low-density lipoprotein into pregnenolone. Pregnenolone is the rate-limiting step in the production of all adrenal cortex hormones. If you look at that chart, you'll see that it's demonstrating the three zones: the zona glomerulosa, the zona fasciculata, and the zona reticularis. Then you see the very first thing, at the top of that flow chart, you have cholesterol, because cholesterol is required for the start of all hormones. Then you see that it's got a little note off to the side, mitochondria, and then you have your enzymes, and then it's converted into pregnenolone. From pregnenolone, you'll have the different synthesis to achieve the end goal or the end steroid hormone for that particular zone. Aldosterone, as I said before, is classified as a mineralocorticoid produced in the zona glomerulosa. About 60% of it travels bound to a plasma protein, and it has a half-life of about 20 minutes, so it's not active for really long in the system. Mechanism of aldosterone release. Kidneys have sensors that detect either blood volume or low sodium. These sensors are the juxtaglomerular cells or magnedenza cells. Low sodium, also known as hyponatremia, will stimulate the kidney to release an enzyme called renin. Aldosterone function. Aldosterone stimulates the kidneys, sweat glands, and salivary glands to reabsorb sodium and for the kidneys to excrete potassium. For every ion of sodium that the kidneys reabsorb, it will excrete 1 ion of potassium. Renin stimulates the conversion of angiotensinogen, a plasma protein produced by the liver, to angiotensin 1. Angiotensin converting enzyme, ACE, converts angiotensin 1 into angiotensin 2. As a side note, this is where most high blood pressure medications work. They inhibit the angiotensin converting enzyme, so they're called ACE inhibitors. Angiotensin 2 stimulates the adrenal cortex to release aldosterone. Let me tell you a little love story about Big Al and Sodi that might help you remember the renin, angiotensin, aldosterone system. In this story, Big Al is aldosterone, Sodi is sodium, Angie is angiotensin, K is potassium, Jux is juxtaglomerular cells, Mac is macula-densa cells, and ACE is angiotensin converting enzyme. It all starts at Kingpin Kidney's nightclub. You see, Kingpin Kidney is the boss of the neighborhood. All circulating traffic goes through his nightclub. Naturally, being the boss, Kingpin filters all the goods coming in and takes his cut. Kingpin's security team, Jux and Mac, monitor the front door, making sure the flow of goods is moving along at a steady pace. Late in the afternoon, Jux notices that collections are getting low and traffic is slowing down. "Hey, Mac! It looks like the flow is decreasing. We need Big Al in here to turn up the pressure." Well, Mac can't leave his post, so he sends his little nephew Renin to go find Big Al. Renin knows that Big Al hangs out at Outer Zone Laser Tag, where Kay works. The Outer Zone is too far for Renin to ride his bike, so he heads home to get his twin sisters Angie 1 and Angie 2 to help. When Renin runs into the house, he calls for Angie 1. He doesn't bother to call for Angie 2 because she's always on the phone talking with her boyfriend Ace. "Angie, I need your help." "What is it, little bro?" "Jux and Matt just said that business is dropping off, and they sent me to get Big Al to fix it." "You can't go get him by yourself." I know. That's why I came home to ask you to help me." "Well, Renan, I can't leave you now. I've just put a cake in the oven. Let me ask if Angie 2 can help." "Hey, Angie! Angie! What? Can't you see I'm on the phone?" "Angie, you're always on the phone. Listen, Rennie needs your help. He needs you to go get Big Al and tell him that things are slowing down at the club, and Jux and Max want him to come by and put the squeeze on to increase the pressure." "Okay, I'll ask Ace to give me a ride." Ace and Angie 2 head off to find Big Al. Once they reach the outer zone, Angie 2 gives Big Al the message. Big Al takes off immediately toward Kingpin Kidney's nightclub. On the way, he stops at Salt Lick Bar and Grill. You know that place, it's just behind the Beacon. As expected, he finds Sodi shooting pool with the Waters gang. As soon as Sodi sees Big Al, she drops her cue stick and runs into his arms. You see, Sodi and Big Al have this kind of off-again and on-again relationship. Sodi adores Big Al, and whenever they are together, she sticks to him like glue. But Sodi is also a free spirit, and she likes to circulate around town. And everywhere Sodi goes, the water gangs follow.
"Hey, Sodi, do you mind coming with me to Kingpin Kidney's nightclub? I have some business to take care of there, and I sure would like your company."
"Oh, Big Al, you know I'll go with you anywhere. But..."
"But what?"
Can the Waters gang come with us? You know they follow me everywhere."
"Sure, I can put 'em to work."
"Hey, wait a minute.
Is that little twerp Kay gonna be there? You know she has a crush on you. I'm not going in that nightclub if she's in there. Don't worry about it. I'll go in there first. If Kay's in there, I'll make her leave. I'll even make her go out the back door so you don't even have to see her. Oh, Big Al, would you do that for me? Yes, my dear Sody. I'd do anything for you.
Aldosterone can affect pH of blood towards alkalinity. Kidney collecting tubules secrete hydrogen ions in exchange for sodium ions. So for every sodium ion in, it secretes a hydrogen ion out. Aldosterone function. In the body, water follows salt. Therefore, aldosterone ultimately increases extracellular volume, specifically blood. Increased blood volume will increase blood pressure. Abnormal secretion of aldosterone can cause problems. Excess aldosterone can lead to hypokalemia because of too much excretion of potassium, as the aldosterone causes the kidneys to reabsorb sodium in exchange for potassium. It also can cause mild alkalosis because of the kidney tubules exchanging a hydrogen ion for a sodium ion. This can lead to musculoskeletal contraction weakness and affect transmission of action potentials because these tissues, all body cells, need to have the proper balance of sodium and potassium inside the cell and outside the cell in order for normal depolarization and repolarization of neurons and muscle cells. Abnormal secretion of aldosterone continue. If there is a decrease in aldosterone, this can lead to hyperkalemia because the kidneys aren't excreting enough kalemia. This can cause abnormal cardiac muscle cell contraction and lead to weakness of cardiac muscle and arrhythmias. Now we're changing gears and going on to cortisol. 90 to 95% of cortisol travels bound to plasma protein called cortisol binding globulin, CBG. It's also known as transcortin. And if you look at the word transcortin and take it apart, you can see trans could stand for transport, cort for cortisol in the blood. So it transports cortisol in the blood. It has a half-life of 90 minutes, so that's a good long time for the hormone to be effective. It is classified as a glucocorticoid and is produced in the zona fasciculata, and production and stimulation is controlled by adrenal corticotropic hormone released from the anterior pituitary. Types of cortisol effects. The two main physiological effects of cortisol is to increase blood glucose and decrease the immune system response. Circadian rhythm of cortisol. Secretory rates of cortico-releasing hormone and adrenal corticotropic hormone and cortisol are high in the morning and drop around midnight on a 24-hour cycle. So about 2 hours after you wake up, that's when cortisol is at its peak. Inhibitory effect of cortisol. It's on a negative feedback system like most hormones. High concentrations of cortisol will signal the hypothalamus to stop releasing corticotropin releasing hormone and the anterior pituitary to stop releasing adrenal corticotropic hormone. And then the low concentrations of cortisol will have the opposite effect. Cortisol's effect on blood glucose. Well, I said before, it significantly increases it. And it does this by stimulating the liver to produce glucose and to store glucose in the form of glycogen. It does this through gluconeogenesis. So mainly it stimulates gluconeogenesis. But the liver is also on an automatic cycle. When there's high levels of glucose circulating, it also will stimulate the liver to start to store it in the form of glycogen. How does cortisol stimulate the liver gluconeogenesis and glycogenesis? Well, it does this by first mobilizing fatty acids, and then it mobilizes proteins. It enhances amino acid transport and it increases the required enzymes for these processes. So how does cortisol affect glucose uptake by skeletal muscle and adipose? Well, it may reduce insulin sensitivity of skeletal muscle cell membranes and adipose cell membranes. Unlike growth hormone, we know that growth hormone specifically inhibits GLUT4 receptors. Not quite sure on the physiology with cortisol, but we know that it does affect it. What happens is it'll reduce the insulin sensitivity, which will then decrease utilization of glucose by skeletal muscle and adipose tissue, which will increase glucose circulating. If you have increased glucose circulating, it's going to increase insulin because the pancreas is going to pick up on all that excess or high level of glucose, and it's going to have a reaction by producing and secreting insulin. Well, this can lead to hypercalcemia and adrenal diabetes, very similar to how excess growth hormone led to anterior pituitary diabetes. Cortisol's effect on fat metabolism. Cortisol is ketogenic. Normal levels promote mobilization of fatty acids from adipose tissue. It increases their use for energy metabolism, very similar to growth hormone. But excessive levels causes specific obesity, a deposition of fat in the chest, in the head, and specifically across the shoulders in the back. What happens is all this, if there's too much cortisol, if it's hypercortisol, then you'll have so many fatty acids mobilizing, but instead of continuing to promote them for use in metabolism, it just redistributes them. So individuals that have conditions with hypercortisolism, they'll have very, very thin, lean extremities, but their trunk and across the shoulders, and particularly right around C6, they'll have a huge fat pad where the fat has been just redistributed. Cortisol's effect on protein metabolism. Cortisol reduces protein stores in almost all body cells except hepatocytes. It decreases protein synthesis while increasing protein catabolism in all cells except hepatocytes. It does promote plasma protein synthesis. It enhances transport of amino acids into the liver, which is necessary because it promotes gluconeogenesis and glycogenesis. Now here's the problem. It decreases the transport of amino acids into skeletal muscle, so too much cortisol can lead to weak muscles. It also decreases protein synthesis and diminishes lymphoid tissue, and that can lead to a decrease in some white blood cells maturing. I have production here, but we know white blood cells are produced in spongy bone, but many of them mature in lymphatic tissue. So a big effect, when normal levels of cortisol are circulating for its 90-minute half-life, it really does not harm any types of protein stores. But unlike growth hormone, it is not a protein sparer. It will cause every cell in the body to dump all their amino acids, so those cells don't have their amino acid stores to make the proteins they need to make. So it leads to a lot of atrophy and degeneration if there's too much cortisol. Cortisol is the stress hormone. Virtually every time the adrenal medulla is stimulated by the sympathetic nervous system in response to stress, the adrenal cortex, specifically the zona fasciculata, will release cortisol. Cortisol release is believed to be stimulated by acetylcholine. And we know that all preganglionic autonomic nervous system neurons release acetylcholine. Don't know exactly the real physiology on it, but that's what happens. Cortisol in the hippocampus. Stress increases mental alertness in most circumstances. When the sympathetic nervous system is activated, you are more aware of your surroundings, and that's because it stimulates the hippocampus. The hippocampus, we know, controls short-term memory. The hippocampus has the highest number of cortisol receptors on it of any CNS tissue in the body. Cortisol increases hippocampus activity. Long-term exposure to high levels of cortisol kills hippocampal neurons. Therefore, it affects short-term memory. Neurons can regenerate their axons when the cortisol levels decrease, as long as it decreases within an appropriate amount of time. So what this means is, if a student is stressing so much over studying information, they physiologically will not be able to remember it because they're killing their hippocampus. So you set yourself a schedule, you study what you can, you learn what you can, and you don't stress over it. If you didn't get it the first time, you try it again. If there's a couple of courses that I took in chiropractic college I enjoyed so much, I took them a second time. Sometimes you just need to give the hippocampus a break. ACTH and melanocyte stimulating hormone. Melanocyte stimulating hormone stimulates melanocytes to produce melanin. Well, the anterior pituitary rarely releases that. However, the adrenal corticotropic hormone that it does release contains a melanocyte stimulating hormone sequence. And if you don't remember, melanin is a brown pigment within the skin. Therefore, excessive levels of adrenocorticotropic hormone secretion is going to affect skin color. It's going to cause it to darken, but it actually causes an interesting bronzy glowy color, which we'll talk about when we get to conditions. Cortisol effects on inflammation. As I talked to before, one of the main effects of cortisol is to decrease or sort of slow down the immune response. It doesn't want to stop the immune response. It just wants the immune response to be in an orderly fashion. And it does this first by stabilizing lysosomes. When a tissue is damaged, its lysosomes also can rupture, and lysosomes contain proteolytic enzymes. So it helps to reduce the proteolytic enzymes reduced into surrounding tissues, because that can damage more tissues. It also decreases vasodilation of arterioles and permeability of capillaries. It does this by suppressing histamine. When you have a inflammation, this example shows a thorn going through the skin. When you have any kind of tissue damage or an microorganism getting into the tissue causing more damage, first thing that will happen in the immune system, it's going to release histamine to vasodilate the blood vessels so that more blood cells can get to the injured area, specifically white blood cells, neutrophils, and basophils, and eosinophils, and microphiles, and all those kind. Well, anyway, this increased vasodilation can also lead to extreme swelling, and then the swelling can get to the point where there's no room for more blood cells to enter the damaged tissue to do their job. So cortisol helps to slow down this process and allows an orderly fashion of the white blood cells to arrive in the area and do their job. Cortisol on effects on inflammation, as I said, it'll decrease migration of white blood cells and phagocytosis of damaged cells. Because if you have too much phagocytosis too soon, those cells get too bloated, and it's hard for them to even be transported out of the area. It also decreases prostaglandins and leukotrienes. We talked about prostaglandins in neuro and muscle physiology when we covered our module on pain. Prostaglandins play a significant role as a part of the chemotaxis that's released when tissue is damaged in stimulating nociceptors. It suppresses the immune system also by reducing the production of lymphocytes, and it does that again by affecting protein catabolism and reducing actually the size of lymphatic tissue. It also attenuates fever. It is a fever reducer, and it does this by stimulating the hypothalamic temperature control system. Now we're moving on to conditions that are caused by abnormal adrenal gland function, such as Addison's disease and Cushing's syndrome. Addison's disease does not affect the hypothalamus or the anterior pituitary. It only affects the adrenal cortex. If you look on the right, you'll see two images of an adrenal gland. The one that's on the top is the damaged adrenal gland where the cortex is nearly gone. It's atrophied, and the bottom one is normal. So this condition only affects the cortex. It does not affect the hypothalamus or the anterior pituitary. So they will still be able to release their hormones. This Addison's disease will lead to an increased secretion of adrenocorticotropic hormone. It's caused by primary atrophy of the adrenal cortex, most commonly associated with the autoimmune dysfunction, but it also can be caused by tuberculosis. Addison's disease causes hypoadrenalism, or you could say hyposecretion of adrenal cortex hormones. That leads to a decreased secretion of cortisol and aldosterone. It also will decrease the secretion a little bit of androgens, but that is so minuscule it really doesn't cause any noticeable signs or symptoms. Decreased cortisol will lead to hypoglycemia because it's normal for the body to have this circadian rhythm for 90 minutes every morning to increase glucose. So if you don't have that, if the liver doesn't have the ability to stock up on glycogen early in the morning, it's not going to be able to maintain glucose levels throughout the day. And it's also going to cause an overactive immune system if you don't have enough cortisol. Addison disease also decreases aldosterone, which leads to hyponatremia, decreased sodium. And if you don't have enough salt to hold on to the water in the extracellular fluid in the blood, then you're going to have low blood volume, which is hypovolemia. And then it can lead to circulatory shock if you do have a significant drop in blood volume and an acute drop of blood volume, And then it can lead to hyperkalemia, increased potassium, because you're not having the aldosterone kick out the sodium. And we talked about what hyperkalemia can do and can cause cardiac weakness or arrhythmias. You're going to have increased adrenal corticotropic hormone release because, as I mentioned before, the autoimmune disorder of Addison's disease does not affect the hypothalamus or the anterior pituitary at all. So they're going to still release their hormones because they're picking up on negative feedback that there isn't enough adrenal cortex hormone circulating. So that's going to stimulate them to continue to secrete their hormones. Well, as we mentioned before, ACTH has a segment of melanocyte-stimulating hormone within it. So if you have hypersecretion of it, and it doesn't have anything to do, it doesn't have any receptors on the cortex to bind with, it's going to cause a change in the pigmentation. Now here I have listed a copper color that the affected person will exhibit. I have seen it as a bronzy glow color. To me it looks like the person has put on some gold glitter. So it doesn't really make them change so much the brown color that's associated with melanin, but it does give it a shinier, golder, shimmery color to their skin. Cushing's syndrome. This is hyperadrenalism. So you've got increased secretion of cortisol, aldosterone, and androgens. This image of a female who has Cushing's syndrome is a classic image. You'll see the round face. They have what's called a moon face because of accumulation of edema. from excess aldosterone. The redistribution of the fat from the cholesterol, liberating so many fatty acids, but they're not getting used up, so it just redistributes them. And you see what's called purple striae that's across the chest there. And that's purple striae is caused from the dermis tearing from increase of the fat distribution rather quickly. I don't know that you can see it, but this female has hirsutism. And hirsutism is male pattern hair growth on the face, and that's caused from the excess androgens. Cushing syndrome is caused by hypersecretion of adrenal corticotropic hormone. So in this case, the adrenal cortex is fine. There's nothing wrong with it. It's healthy and it can produce all the hormones. It may get tired, but it can continue producing. So this Cushing syndrome does not affect any damage to the cortex itself. What's problem is that the anterior pituitary is secreting way too much adrenal corticotropic hormone. This can be caused by a tumor in the anterior pituitary. It also can be caused with a problem with the hypothalamus, hypersecreting corticotropin releasing hormone. And it also can be caused by ectopic tissue that produces adrenocorticotropic hormone that could have migrated off during the embryology phase, and it often is associated or is found in the lungs. And if you have a lung tumor, it actually will cause, if this lung tumor is in one of those ectopic tissues that secrete adrenocorticotropic hormone, it can also lead to Cushing syndrome. Long-term use of synthetic cortisol can also cause this. Long-term use of cortisol, pharmaceutical cortisol, I have listed here prednisone, or way too many injections for inflammation. You'll find that many of your senior patients will have this because they have chronic arthritis, either osteo or rheumatoid. It is an amazing anti-inflammatory. We already told that's one of its main functions. Cortisol is to reduce inflammation, and it's very effective. But it also, if you use it too much, it can actually lead to Cushing syndrome. The hypercortisolism associated with Cushing syndrome leads to increased blood glucose concentration with a decreased glucose utilization. Remember, it inhibits skeletal muscle and adipose tissue from taking up the circulating glucose, and it'll stimulate the liver to produce too much glucose through gluconeogenesis, so it can fatigue the liver and redistribute the fat, have too much fatty acids circulating, and then it's going to lead to muscle weakness because the muscles can't take up the glucose for energy, and it's going to cause the muscles to release too many amino acids. Cushing's syndrome hypercortisolism also leads to increased protein catabolism. It decreases tissue proteins in almost the entire body except the liver. It diminishes the availability of proteins, coupled with the loss of protein synthesis will cause muscle weakness, very severe muscle weakness, suppressed immune system due to the decrease in lymphoid tissue. So after a while, if the cortisol is circulating or is too high for too long, the body tissues are going to run out of stored proteins. So the largest resource of proteins in the body is skeletal muscle, and the cortisol will actually cause the skeletal muscle to catabolize its own proteins to dump the amino acids into circulation. And that will then lead to muscle atrophy. Hypercortisolism is going to diminish the availability of proteins, and that, coupled with the loss of protein synthesis, is going to decrease collagen production. Well, skin and bones need collagen. That's going to lead to the thinning of the skin due to the decreased collagen. That's going to have the person, they'll bruise easy, and then they develop those purple striates that I talked about at the beginning. So that's going to be a classic sign. Lots of bruises, purple striae, thinning skin, classic fat distribution, very lean extremities with a large abdomen and large fat pad across the back of the shoulders. And then it can lead to osteoporosis because bones need collagen as well as a hydroxyapatite matrix. So it needs to have the collagen to strengthen bones. Classic buffalo hump across the shoulders here. Hypercortisolism leads to the fat distribution, especially the upper body, and causes upper body obesity. And fat moves from the lower body and the arms and to the trunk, upper shoulders, neck, and the clavicle. And then you see again, I'm going to mention again the buffalo hump across this person's back. All right, Cushing's syndrome is going to increase aldosterone, which is going to increase water retention because aldosterone causes the kidneys to reabsorb sodium. Water follows salt, so it also causes it to reabsorb water. This will lead to edema, and they'll have a classic moon face. You see that in this individual here. They have a classic moon face, and it can cause hypertension. About 80% of all patients with Cushing's syndrome is going to have some form of hypertension, high blood pressure. The hypersecretion of the androgens is going to cause, in females, hirsutism. You don't really see too much difference in males. But the hirsutism you may see in this image here is male pattern facial hair. That can be caused with hypercortisolism. They can have menstrual irregularity. It'll decrease fertility and libido in men. Very similar to complications with thyroid hormones. And it can lead to fractures, particularly in the vertebral body. It can lead to fractures in the ribs and the feet, but the most common area is compression fractures in the vertebral body. And that's because of the lack of collagen to strengthen the bones. And individuals will have back pain from weakness. It's very important when you get into clinic and you're starting to work on patients that any female that is postmenopausal, you ask them how long has it been since they've had any kind of cortisol medications like prednisone or any hydrocortisol injections, because you want to find out how much of that's been in their system that could have caused some compression fractures and might be actually a source of their back pain.